Hello, everyone. Thank you for joining us here today on the special Preemie Chat. I'm Fabiana Bacchini, Executive Director of the Canadian Premature Babies Foundation, CPBF, and a mother of surviving twin born at 26 weeks. And I have here joining us live from Halifax, Leah Whitehead, who's a journalist and also parent of a preterm baby born at 28 weeks. Thank you so much for joining us here today, Leah.
Thank you for having me today for this exciting day.
Yes, and we do have a lot of on the lineup today, which is so great. And for those who don't know CPBF, we are a charitable organization, and our mission is to empower families of premature babies through support and education. The Preemie Chat series is one of the many initiatives we have to bring information for NICU families and healthcare professionals. Also on our website, canadianpreemies.org, you can watch past sessions and you'll find all kinds of resources and support.
The care of extremely preterm babies has evolved greatly over the last few years, and survival and outcomes have improved, and infants born as early as 22 to 24 weeks that were previously considered non-viable are now surviving. NICUs around the world work tirelessly to improve overall care, and yet there is so much more to be done. And that's not only in research and quality improvement, but also in the inclusion of families regarding decisions made in NICU, which may affect their infants' outcomes. Today, we are going to discuss different approaches to caring for these tiny babies, including having a small baby unit or program, the golden hour, and the science of the exclusive human milk diet. And leading us in these discussions today, we have Dr. Michael Narvey and neonatal nurse practitioner Terry Johnson. We also have three parents of micro preemie babies to talk about their experiences of shared decisions, feeding challenges and successes, and what life looks like after NICU.
Yes, and I also want to thank ProLacta Bioscience for supporting our educational program. And we are going to get started with our first speaker, Dr. Michael Narvey. He'll be discussing how we can achieve the best outcomes for the most vulnerable babies born at the limits of viability. What can be learned from the smallest infants and how it may impact care at older gestational ages. He'll also talk about the small baby unit and his experience with feeding this particular population. And I have here joining us live from Winnipeg. Let me just bring him to the studio.
Hello.
Hello, Dr. Narvey. Dr. Narvey is the section head of neonatology in Winnipeg, medical director of the Child Health Transport Team, associate professor in the Department of Pediatrics and Child Health investigator in the Children's Hospital Research Institute of Manitoba. He's the chair of Canadian Pediatric Society's Fetus and Newborn Committee since 2019. His interests predominantly lie in the use of no-invasive technology to minimize painful procedures during an infant stay in the NICU and neonatal nutrition. He's active on social media and always bringing great information for healthcare providers and families. Dr. Narvey, thank you so much for joining us here today.
Absolutely, my pleasure to be back. Thanks for having me.
Okay, and for all of you watching us live, please do send your questions, your comments, and Dr. Narvey will address them at the end of his presentation. Dr. Narvey, the floor is yours.
Thank you very much. So what we're going to talk about, as you've already heard, is whether small baby units are the future of neonatology. And I'm also going to give you an update as to where we are with the exclusive human milk diet. I'll state up front that we don't use or don't have a small baby unit here in Winnipeg, although it's something we've certainly been discussing. And for those of you who were, I'll make a little plug for the Canadian Pediatric Society. There was a great talk on this actually this year by Dr. Mike Dunn out of Toronto, who I think many of the listeners will be familiar with. So I'm speaking, when I talk about this topic, I'm speaking from the perspective of what I've read, not what I've done. But I think it's a very interesting and emerging aspect of potential care as a model for units to move towards. And we'll discuss the benefits and we'll discuss some of the pitfalls. So the first objective is to define what exactly are we talking about when we talk about a small baby unit. Then I'm going to go through 4 principles for success that I think a small baby unit must have to provide the best chances for success. And we're then going to finish by talking about what are the barriers to the future spread of this approach before moving on to that brief update on exclusive human milk diets, especially what we're doing in Winnipeg. So let's define what is a small baby unit. So small baby units, this is nothing new. For those of you who have been following neonatology for some time, you're probably aware that you've heard the term small baby unit for a long time. The CNN, not the CNN we're used to here in Canada, but the CNN from the media covered this in their piece back in, I believe, 2014, called Tiny Survivors, Special NICU Mimics Mother's Womb. And there are these small baby units that have been popping up around the US. We see them in Nationwide Children's, we see them in Southern California. And the box on the right is meant to designate, and I'll use it throughout the presentation, small baby units where it's not, when we think about a small baby unit, some people think that this would be a unit that is exclusively for babies, let's say under 28 weeks or under 1,000 grams. But the reality is, unless you're in a very large population, you would not be able to have a unit that was filled with enough of these babies to be a standalone unit. So for the most part, when we talk about small baby units, we're talking about, as you see there, the box within a box, we're talking about a section of the intensive care that would be designated as the small baby area. So principle number 1, everyone needs to march to the same beat of the drum. If you are going to have a small baby unit, you have to band together and you have to decide what is best care. And the consistency of care is actually what matters. There are many dozens and dozens of papers that have looked at small baby unit care. I can't possibly hope to cover them all today. I'm going to give you a smattering of what I consider to be some of the more important papers in this subject area. And we're going to begin with a paper from 2010, which really, I think, was the first great description of implementation of how one would create a small baby unit in order to improve outcomes. And as I mentioned, this comes from Nationwide Children in Ohio, in Columbus. So one of the questions that I know Fabiana was hoping I would get to is, when we think about providing the optimal care for small babies, what are some of the things that might be included in a bundle for such care that everyone would ascribe to? So one of the things that has really been sweeping the nation, I think, is the practice of midline head positioning and minimal handling for the first 72 hours, with the idea being that this is best for their neurodevelopment and potentially avoiding kinking as you turn the head from one side to the other, kinking of the draining vessels of the head, leading to blood, having back pressure in the SVC, potentially leading to IVH. So to try to reduce IVH, we do that. In Nationwide Children's, they did that as part of their bundle. They looked at using 80% relative humidity for the first 3 days and 60% for the remainder of the first week of life. And these were for all infants, generally less than 27 or 28 weeks of age. In their center, they used prophylactic indomethacin. I know that that is controversial here in Canada. They had a very standardized approach to hypotension, which some people might challenge, but they used dopamine, then hydrocortisone. And they had a promotion of the use of non-invasive ventilation very early on in the care, which is, I think, where a lot of people have moved to. And they also tried to minimize blood work, so minimize the painful exposures. And also, the more tests you do, as you know, the more tests you do, the more likely you are to find something abnormal, which actually might just be a variation of normal. And so that then, rather than going down the rabbit hole of chasing that with more pokes, they try to minimize blood work. And as you'll see with the box within a box, this was a unit within a unit. And so the idea here was, let's create a team, let's review the literature, let's come up with best practices, and let's get everybody to stick to it. So what did they find? So as I mentioned, these babies were all 27 weeks or less. What they found was when they created the small baby unit, and what they did was they looked at a year prior to the small baby unit being developed and then the year after, and they collected data during this time because they wanted to see if you do a back-to-back comparison. So it's not a randomized trial, but if you do a back-to-back two-period comparison, what you then are able to look at is you're able to make some assumptions that the care during this time did not change dramatically. For example, you wouldn't have changed your ventilation strategy. You wouldn't have changed the isolettes you use or incubators you use. You might not change your bilirubin lights. The care providers are generally the same. And what they found was that the mean length of stay for survivors was significantly reduced. It was reduced by a mean of about 33 days if you were in a small baby unit. When you look at the things that were significant, in terms of patient outcomes, survival in the first week was 97% in the small baby group, 83% in the control. Survival to 28 days was not significant, nor was survival to discharge, but that early survival was. If you look at BPD, bronchopulmonary dysplasia was much higher, was 17% higher, although just missed statistical significance. Ventilation was 17 days shorter, but days on CPAP, which was significant, not surprisingly, was much higher. If you use an intention to provide CPAP early instead of ventilation, that's why you would see more CPAP days. And finally, when you look at the combined outcome in survivors, which is obviously very important, survival without BPD was almost 3 times less, 3 times more, I would say, in the small baby unit compared to the traditional approach. Severe IVH was roughly halved in terms of incidence, and survival without BPD or IVH was 1/4. The reverse was 4 times as high in the small baby unit. So what they demonstrated here was that bundles of care that everyone ascribes to, small groups with small numbers of neonatologists, small numbers of nurses, small numbers of RTs that are dedicated to the care of these infants and try to provide consistent care, leads to better outcome. Principle number 2, too many cooks spoil the broth. So for here, examples of this and how one does this, you can go back to 2021, where Anchorage, Alaska developed something called the We Care Team. Similar idea to what was done in 2010, and they focused on infants under 1,000 grams, and recognizing that they only see 30 to 60 babies per year, they opted to use the unit within a unit. So what they did was they sought to recruit, and importantly, I know the CPBF is very strong on parent representation and advocacy for parents, and they wanted parent representatives on the core team because the theory was that if you're going to build a small baby unit, you want to have, at the very center of the team, you want to have the parent. So they recruited 30 nurses, a family navigator, or somebody that might be considered, as we have in Winnipeg, a veteran parent, an NICU educator, a developmental therapist, a unit medical director, and a lead respiratory therapist. And by keeping the group small, the goal was, again, consistency of care. In terms of developing from the paper, they show that they looked at PBFs. They identified focused PBFs. These were potentially best practices. So they started off from a humble standpoint, saying, we've reviewed the literature, we believe that these are potentially best practices. And so as part of building the We Care team, they test the theory. So I won't go through the whole slide, but what you can see is over a period of about 1.25 years, what they do is they go and make visits to other centers. They look for best practices. They roll something out. They audit it. They make sure that it works. Then what they do is they have quarterly team meetings where they can review what they've done. They can review the outcomes, and they can make sure that they're doing the right thing. The challenges that they identified, and this, like everything in life, it's about communication. So one of the challenges was for the whole team to understand when a change was being done, why. Why are we making this change? Does it make sense? Is it in the best interest of the baby? Is it in the best interest of the parents? The other thing that they had challenges with is elitism, the concept that people may feel excluded. And we'll talk a little bit more about that later. Their main interventions, I shared with you what the 2010 nationwide group did. Their main interventions were they looked at development of education based on a review of the best evidence for ELBWs. And this focused on how they give surfactant, the promotion of starting non-invasive positive pressure support soon after birth. They wanted to avoid low carbon dioxide levels, which is not good for cerebral perfusion. They wanted to minimize excessive ventilation and standardize the way they ventilate these babies. They wanted, again, the neutral head positioning for ELBWs to prevent IVH. And they really wanted to focus on something, if there's any RDs listening, they really wanted to focus on optimizing nutrition in this population. And what a difference teamwork can make. This is from their paper, which showed, remember, they started the intervention back in early March 2014, is when they started looking at different strategies and optimizing what the best care would be. In 2015, they had quarterly team meetings. And so the incidence of severe IVH dropped from 15% down to 12%, then down to 4% by 2016. CLD rates between 2014 to 16 dropped from 40% down to 19%, and then only rose slightly up to 25%. So what they were able to show, and this is very important, when you're looking at evidence to support a small baby unit, you don't just want to see in the initial stage that there's a reduction in harms and benefits. What you want to see is that it's sustainable. So in the year after the intervention had rolled out, you can see IVH rates were continuing to fall. CLD rates were marginally up, but I would still say for 25% rate of IVH is far better than 40%. Now, what about principle number 3? This is a bit touchy. As Malcolm Gladwell said in his book, Outliers, it takes 10,000 hours of deliberate practice to become an expert. Now, if for those of you who follow the 10,000-hour rule, you would know that there's a lot of debate in the literature about and media as to whether or not you need 10,000 hours. But if you'll indulge me, what this really has to do with is the more you do something, the longer you do something. The more exposure you get to the ELBWs, the better your outcomes are going to be. And so the same nationwide children's unit that published in 2010, that Pinnacle paper, in 2022, so this is extremely recent, Fathi et al. Just took a look at the last 12 years of outcomes. And they wanted to see, really, what has this small baby unit accomplished? And so what they have found is that over time, severe IVH has statistically been reduced in their babies under 27 weeks. And when you look at age at discharge, which is figure C, the small baby group, which again for nationwide is it's a unit within a unit, the small baby group has had a statistically significant reduction in length of stay. Looking at it another way, parents are getting to take their babies home healthier and sooner than they traditionally did. I mentioned 10,000 hours. I also mentioned that there's been a lot of literature. What I'm showing you here, and I don't expect anyone to read this, is figure 4 from their review of the last decade of their work in the area. I didn't count them all, but there's probably 15 or 17 papers here that have been produced from this one center demonstrating experience with improved outcomes in this population. And so if one was looking to model themselves or looking to see how success is achieved, I would say looking at a unit like the one that they have in Columbus, Ohio, with this vast published experience would be a good place to start. Principle number 4 is auditing. This is something that is not always easy to do. I don't know about your unit, but in our unit, we make changes all the time. As evidence changes, you get different ideas, you get where parents will suggest, can we try something? Excuse me. So you try something new, but how do you know that it works? You know that it works through auditing. The way we audit these days, or the way we should be auditing, is by the use of PDSA cycles. And you've probably heard of this before. Plan, do, study, act. So you, just like I talked about it in the 2 papers that I've shared with you, at the core of the approach to the small baby unit is to look at your population, look at the evidence, create a bundle. That's the do. So create a bundle of care that you believe is, at the moment, the best approach to care for these babies. Then you need to audit them. You need to look at your outcomes before the intervention, look at your outcome after the intervention. Once you know whether it was a success, you need to decide, is there anything further that can be done to augment that success, or is it time to move on to the next bundle? That's the act piece. And then that's the act leading into the plan. So that's essential if you're going to have a small baby unit, to know that you're actually making a difference. What are some barriers to success? Kangaroo care is something that we know is so important for the development and stability of the babies in our unit. If you're going to have small baby units, it's critical that kangaroo care be promoted. It's not so much a barrier, but what if you don't have families? That's where cuddler programs can be very beneficial. Making sure that the babies have the stimulation that they need for proper development. Another issue on the right, the cartoon says, patient laying in one bed and there's a woman laying in the other bed, says, "You don't look so good. Should I call the nurse?" And she says, "I am the nurse." When you have, so this is a barrier. When you have babies under 27 weeks, although I think I've shown you that the outcomes of these babies could be better, nonetheless, they're very resource intensive. They're very stressful at times to take care of. They can get quite sick. And if your team is only involved with caring for these really sick babies, that can take its toll on your staff, leading to sick calls, leading to vacancies. And so you also will need specific staff who are able to staff such a unit. And if you have vacancies related to lack of hiring in the area, and you need these trained nurses, the nurses that are there, if there's shortages, will be overworked. And so one has to manage that. Fatigue. The other thing that happens, and I don't think I'm out of line in saying this, because I had a chance to speak to Eugene Ng, who some of you may know, but also Mike Dunn, about small teams and that sense of exclusion. Because you can imagine, as a neonatologist, I work in a group of 15. If I want to make sure that there is consistency of care in the babies that I'm caring for, having 15 people involved is probably not the right way to go. You want to have smaller groups that you can achieve better consistency with. The other thing that you'll see when you have smaller groups is they're doing more service. And when you do more service, you get to know the babies better. So for example, if I get called about a baby that I don't know very well because I'm just parachuting in for a call, and they tell me they're having more apneas and bradycardia, I might do a septic workup. Whereas if I've been on service 2 out of the last 4 weeks, and I know this baby does this every couple of days, I might have more tolerance, less poking, less investigations, less antibiotics. And so, as Albert Einstein said, ego is equal to 1 over knowledge. And so the more knowledge we have, there's an inverse relationship. So knowledge, another way of saying this is a little knowledge can be a dangerous thing, and ego can get in the way of doing sometimes, I think, what is right. So are small baby units the future of neonatology? I think if you define it in the way that I've defined it, with the sense that small groups caring for babies in a portion of the unit which uses best practice? I think the answer is yes. I think the positives are that evidence-based practice is used, that all team members buy into. I think that if you have a situation, as I know it happened at Sunnybrook Hospital, where the concept of having a small isolated group to manage these infants did not work. I won't go into the reasons for that, but you could certainly ask Eugene or Mike about that. If you're going to say everybody participates, then you need to at least use a small working group so that you don't have too many cooks. And once the working group has come up with their recommendations, everyone has to buy into it. You need to adhere to the protocols that are put in place. Consistency, I believe, is where the advantage occurs. You need regular evaluation of practice change to determine if there has been a positive or negative impact. And I realize here I'm preaching to the converted, but in every situation, if you put the babies and the needs of the family first, I think that's what needs to drive the process. Every time you make a change, you need to ask yourself, is this decision in the best interests of the baby and the family? And to put it another way, leading up to what I'm really thinking about, as a neonatologist, if I believe that we cannot achieve with a large group consistency, maybe I need to step aside and let a smaller group take care of these babies, because that's actually what's in the best interest of the patient, not necessarily what's in the best interest of my own ego. So now we're going to shift gears. Where are we at with exclusive human milk diets? I've spoken about this at some point before, and I've spoken about this on various forums, but back in 2015, as exclusive human milk diets were becoming a possibility with human-based milk fortifiers, we introduced something in Winnipeg which became known as the rescue approach. And the rescue approach went like this. If you were under 27 weeks, if you had one, or under 750 grams, if you had one episode of intolerance to HMF, and we defined intolerance to HMF as significant abdominal distension, increased residuals, emesis, and hematochezia, or blood in the stool, then we would allow the use of human milk fortifiers, human-based human milk fortifiers, and we continued to 32 weeks or 2,000 grams, whichever came first. Greater than or equal to 27 weeks and or greater than or equal to 750 grams, we required 2 intolerances to HMF, and you had to continue for 4 weeks or to 32 weeks, whichever came sooner. We felt very comfortable with this because at the time, based on what the evidence was showing, and knowing that the vast majority of the babies seemed to tolerate bovine sources of human milk, bovine sources of fortifier quite well, we were less concerned about the exposure to the bovine fortifier. But as evidence has come along in recent years, our opinion has changed. At the time, the reason we came up with the rescue approach is we were able to demonstrate in this paper from 2017, when we looked at 7 babies in our, this was early on in our experience with the rescue approach, what we were able to demonstrate was that in these very small babies, with the exception being the one at 33 weeks, patient number 6, the babies were essentially not growing when they were on human milk fortifier that was from a bovine source. In one case, the patients were extremely edematous and were, basically losing protein from chronic water loss stools. And long story short, every baby, once they were switched over to the exclusive human milk diet, recovered and was able to come off of central venous access and grow in a targeted way that met the expectations of our dietitians. So we felt well supported in our in our targeted rescue approach. This is a study that has been quoted many, many, many times. It's Debbie O'Connor and Sharon Unger's study, the Optimum study. This audience, I'm sure, will be very familiar with it because it's been talked about many times. And it's an RCT of 127 babies under 1,250 grams who either received an exclusive human milk diet or a human milk diet that was fortified with bovine fortifier. The important thing that we need to remember about this study was that the primary outcome was the incidence of feeding interruptions. I don't have time to go through the entire study, although I'm sure you've heard it many times. The authors made the point of saying if they wanted to look at things like necrotizing enterocolitis, they would need thousands of patients to find a difference. So they went after something that they felt was meaningful, but it's the secondary outcomes that I'm going to focus on, because when you hear people present this study, what they will claim is there was no benefit shown. But the devil is in the details, because while there was no benefit shown in terms of the primary outcome, looking at times of feeding interruption, 17 in the human milk group, 26.6% in the human milk group, 32.8% not significant in the bovine group, one could very quickly conclude that it's not worth your time. But is feeding interruptions really what it's about? I would say not. So what about morbidity aside from our ROP? So they did what I consider, and I mean that I don't mean any disrespect to the team, it's just they did things in a way that I thought was a bit unorthodox. They presented a mortality and morbidity index, and mortality and morbidity index was death or any one of late onset sepsis, NEC, chronic lung disease, or severe ROP. So this meant if you were a patient who had multiple problems, you could have NEC, you could have CLD, you could have severe ROP, you only counted once. And so they showed that there was no difference. There was a trend towards significance with 35.9% of the human milk group versus 49% of the bovine group having this composite outcome. But it didn't quite reach statistical significance. Interestingly, if you look down at retinopathy of prematurity, severe retinopathy of prematurity, it was about 5 or 6 times, about 6 times or 7 times actually, less common in the human milk group. And curiously, in almost all the studies looking at an exclusive human milk diet, severe ROP has been less. And when you think about the cost to having someone lose their eyesight over a lifetime, this is a very important outcome to consider. But when you look at it another way, if you look at it based on individual outcomes, so let's look at total outcomes, not by patient, but total outcomes in terms of adverse outcomes. And this was done by Alan Lucas. And what Alan Lucas found was, again, the severe ROP was reduced statistically. But when you looked at adverse events per case, what you found was there was a statistically significant difference, with the mean events per case being 0.74 in the bovine source, and human only 0.48. So what this meant was you might not have delayed feeding interruptions or more feeding interruptions, but what you would have is reduced severe ROP, and you would have less overall adverse outcomes. So this is actually relatively new. This happened just a few months ago. We've had a change to our Winnipeg Rescue approach. We still have it in part, but we've made a modification. I talked previously in the study, or in this presentation, about the importance of auditing. So we did an audit looking at our practice of using rescue human milk based fortifiers. And what we found was year over year, we were very consistent in that if you were under 750 grams, or I should say also under 27 weeks, about 2/3 to 3/4 of all the babies we saw, in confession, we only see about 8 or 9 babies in this weight or gestational age category per year, but 65 to 75% of them were getting it, which meant roughly that about 2 babies a year were being exposed to a trial of bovine sources of milk with fortifier, with the risk of blood in the stool, at worst NEC or death, and the rest of them were winding up getting it anyway. Nursing was also finding that, and this is in contrast to what was found in the Optimum study, but nurses were clearly identifying which babies were getting, they could tell the difference between the human fortifier and the bovine fortifier in terms of how the bellies looked, in terms of how they tolerated their apneas and bradycardias, all of these different things. And so an argument was made with respect to health equity being imbalanced between the groups, and that was it fair ethically to expose 2 babies a year to this failure when you couldn't predict, 2 babies who weren't going to fail, but was it still ethical to take the risk when you know 75% of them are going to have problems. So rather than taking a chance and having 3/4 of your babies wind up needing the human form anyway, why not just use everyone, or why not just give it to everybody? And so we did adopt a prophylactic approach for babies under 750, or it should say under 27 weeks as well. And so all babies under 750 grams or less than 27 weeks now receive H2HMF from the time of first fortification until 32 weeks. Above that, the requirement for 2 failures remains the same. I can tell you there are very few babies in the group above 27 weeks and above 750 grams that we see that need to go on to the human-based fortifier. But certainly under 750, that has been a change. And with that, I will close and welcome any questions.
Okay, Dr. Narvi, thank you so much. Oh, let me remove this here. Thank you so
Okay.
much for the incredible presentation. We always learn so much from you, and I really love your perspective of equity, because as a mom who had a child with severe ROP, and I hear reduction of ROP, I would like everything to be done for my child not to have ROP, because the long-term impact of ROP 10 years later, it still affects our lives and my son's life. So I applaud you for all your approach and initiatives and everything that you do in your unit. And we know there's a lot of people who follows you. There is somebody from Pakistan joining, somebody who follows you and love your work. So you see,
nice.
people watch and see what you're doing, how you're doing. So hopefully we can implement changes in many units for better outcomes for babies. So my first question to you is going back to the small baby unit. Maybe I missed that in your presentation, but how is the small baby unit related to the labor and delivery? Because there's so much that happens in labor and delivery that will also impact the outcomes.
Well, I think it's related in the sense that when we talk about small baby units, you designate a core group of people to take care of those babies. Whether you choose to have the resuscitation team be specific to the small babies or not, I think would depend on your staffing models. But my guess is you would generally have one resuscitation team, but the medical direction of that resuscitation team would be a member of the small baby unit, because we know that, you know, what you do in the first 24 hours really sets the stage for much of the rest of the stay. You know, if you aggressively ventilate too much, you don't use non-invasive support, you don't manage blood pressure well. You know, in some centers, they give prophylactic indomethacin. If you don't get that in because you've forgotten, you're not used to doing it, all of that, you know, will impact. I think the other thing that I think is very important is that we need to be able to offer families the best advice possible. Who better to offer the best advice possible than a core group of people where that's all they do, right? So if all you do on that service is care for the smallest babies, then it's going to be more on the tip of your tongue when a family says, and I'm asked this all the time, at 22 weeks, 23 weeks, somebody will say, realistically, what's the likely outcome here? Now, my experience, now, as I said, I'm not working in a small baby unit. We have not adopted that. But I can only see it being an advantage that, much like I talked about the Optimum study, how when people quote the Optimum study, and I don't mean anything disparaging to people, but I'll often hear people say, oh yeah, that showed no benefit. And the devil's in the details. Well, what do you mean it showed no benefit? Like what aspect of it didn't show a benefit? Yes, the primary outcome. But similarly, if I'm on a service where that's really all I see, then I'm going to, at the tip of my tongue, know that when I'm speaking about my experience, it really is that group. Whereas if you're working in a general unit and you're seeing babies that are 30 weeks and 35 weeks, and that's the lion's share. I mean, as much as we think about neonatology as tiny little babies, that is really a tiny, tiny, tiny portion of what we do, right? But it could be something large. And the more experience you have, the more focus you have, you know, the better off the outcomes are going to be. And, you know, the one thing I didn't mention, which I'm glad you asked this question, because some people think it's a bit foreign, the idea of saying, because we treasure, as neonatologists, when we think about why we did neonatology, it was to care for these little babies. But if you go around the country, are you telling me that there isn't an acknowledgement that, let's say, for cardiac care, there should be a small number of neonatologists caring for cardiac babies because it's so specialized? Same thing with neurological. We've got a neurocritical care team here, and it's a small group of neonatologists that have an interest in neurocritical care. Nobody argues about that. Nobody says, no, 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 we should all be caring for cardiac. We should all be caring for neurocritical care, because it requires an expertise. I think the same is true about the tiny babies, and I don't think that we should view it any differently.
Yeah,
Mike,
do you have a question?
I do. I appreciate all the numbers and talking about the outcomes and the differences. I'm just wondering, has there been any qualitative research, I guess, from the parents' perspective or from families' perspective of how they have experienced these small baby units?
So I'm going to plead ignorance on this one. I'm going to say I didn't get to that in preparation for the talk. I'm guessing there is. You know, I mean, I bet you if I went through a fine-tooth comb and looked at that list of 17 or 15 references, there's probably something in there. So you're welcome to take a snapshot of that slide and have a look. I would venture a guess, if I had to bet, somebody's looked at it and interviewed families and presented that. If I had to take a guess, you know, as a division head or section head of neonatology, one of the things that I hear most commonly from parents, one of the most common complaints that we get is the changeover of the neonatologists. You know, they want consistency.
Yeah.
They want the same nurse. You know, they want the same RT. So I can only imagine if somebody was to survey parents that have gone through the experience of having only a few neonatologists, only a few RTs, only a few nurses and so forth, and one dietitian, they'd have to be happier. I can't see how it would be a negative thing.
Yeah, so we have a question here coming from our live audience. Hi, NICU mom and physician here. I'm wondering if there is any benefit in continuing human milk-based fortifier past the 32 weeks. Sean, thank you so much for joining us and for your question.
Well, I'm going to give you the official answer, and I'll give you the off-the-cuff answer, the informal answer. So officially, the company that provides this product recommends that you start weaning it after 32 weeks and usually generally finish by 33 weeks. We have had, as recently as about 2 weeks ago, a request from one of our dietitians to continue on past 32 weeks for an additional 2 weeks. Because at the end of the day, if a baby needs fortification but has an extreme sensitivity to bovine protein, then you run into the problem of, you know, they may not need the fortifier for the nutritional value of it, but if they still need fortification to avoid that water loss stool, to avoid lack of growth, you may need to continue it past that period of time. And so I don't, you know, now I'm worried people are going to quote and say, Dr. Narvey is saying you should use it well beyond 32 weeks. I would say, in consultation with your registered dietitians, or if you have a small baby group, I think you need to look at that and say, on a case-by-case basis, can you sometimes justify continuing it, because it's just far better tolerated by the neonate. Now, last thing I'll say about that is, I don't know if Sharon or Debbie are on this call, they might jump in and say, well, wait, we showed that there's no difference in in feeding intolerance. But I think that's where it's important to also acknowledge what we really mean when we say that. And this is where people, I think, sometimes get confused about research. When we do a randomized controlled trial, when we do a meta-analysis, systematic review, and we come up with the answer is there is no benefit for feeding intolerance. Well, I'm not disputing that. What that means is, you know, it was a well-done study. What it means is that when you're thinking about standard of care, this should not be your standard of care, you know, for all babies, okay? But on an individual basis, so in any study, some babies in the experimental group benefit, some babies in the placebo group benefit. Sometimes it's more in the experimental group, but it doesn't reach significance, as the case of the Optimum study. But what it means is that there are babies that it's making a difference, but they haven't actually shown a significant difference for the whole. So in the end, the way I approach it is for the 32 weeks and over, on an individual basis, I don't care what the research said. If the individual patient is telling me that they cannot tolerate this bovine source, then you need to open your eyes. You need to at least consider that this individual person, it might be in the best interest for that baby and their family.
Now, I actually love this comment, because do you feel there should be a more customized approach to care to some babies? Because yes, the study overall said, yes, it didn't change intolerance, or there's no significance there. But when I look back into my NICU journey, and I remember clearly when fortifiers are added to Gabriel's diet, he started having reflux. Back then, I didn't know anything about anything. I was asking questions, but once they removed that, his reflux was gone. But it was after a lot of fighting over this fortifier, and I didn't understand why I'm breastfeeding or providing breast milk. Why do I need this? So there was a lot of education that I had to receive. But I also feel that there's must be a need for education for families, but also have the flexibility of the care team to customize care for those babies.
I think that's really what it's about. Is, you know, I approach every baby the same, in the sense of, you know, because that's what this presentation is about. It's about coming up with a standard of care that you all agree to, and you implement that standard. But when the patient is not responding to what they should be responding to, I think that's where you need to customize. You need to think outside the box. To your point, last time I was on service, without revealing any identifying characteristics, I had a baby that was on a bovine fortifier and was having reflux all day long. Suspected reflux. We didn't have a camera to visualize it, but we suspected they were having reflux, and was having multiple events a day, 5, 6, 7 events a day with feedings. And I realize as I tell this story, it's going to make me sound like a hero, but it was just an educated guess. And I said, you know, maybe it's the fortifier, you know? And so we took the fortifier out, and it dropped immediately down to 1 event a day, from 5 to 6 events a day. So it was fairly clear. It was such an abrupt change after weeks of 5 to 6 a day, and we took the fortifier up, and it just almost stopped, that we were in part causing the problem. You know, I mean, we were trying to do what should work for every baby, but this was a baby who was telling us that this is not the right approach for them.
Wow, Dr. Narvi, I would thank you so much for joining us here today. There's a lot of hellos for you from all over the world, and for
those very nice.
Missed the beginning of his presentation, we will be available on our YouTube channel. But Dr. Narvi, thank you so much for joining us here today. Always a pleasure talking to you, learning from you. And for all of you watching, please do follow Dr. Narvi on all the social media accounts, because he has great content to share. So thank you.
Thank you.
It is an honor for me to introduce our next guest. It's someone who knows firsthand the challenges that come with having babies in NICU who are born very early. Jessica Lampman is a mother of twin girls who were both born at 24 weeks. As you can imagine, and is often the case, each girl had their own set of complications, setbacks, and milestones. After 152 days, both girls came home on low-flow oxygen, with various teams following them and lots of appointments. They are now almost 3 years old, sassy, silly, and wild little girls, just how we like them to be. And they've done extremely well, hitting all of their milestones and are almost signed off by every team. Welcome, Jessica, and thank you for coming to share your story here today.
Thank you. Thank you for the introduction.
I'll let you get to it. I'm excited to hear about them.
Yeah, thank you. So as Leah said, my name's Jessica Lampman. I'm the mom to Amelia and Harper. So in 2019, my husband and I were shocked to find out we were expecting twins. We began to plan and prepare. We even bought a new house and moved to a new town, but quickly learned with all my research with twins that we needed to expect the unexpected. At my anatomy ultrasound, it was discovered my cervix was extremely shortened and I was put on bed rest immediately. Our OB was very forthright on what to expect. She managed our expectations and was very honest about what could and probably would happen. We appreciated this more than we even knew at that point. At 21 weeks, my water broke with one of our twins. As we drove to the hospital, a level 3 that was nearby, we didn't know what was going to happen. It was quickly discovered I wasn't in active labor, but now I was going to be admitted, and my bed rest would continue. The waiting game began, counting the hours, then the days, and then the weeks. We were hoping our girls would hold on and stay in as long as possible, but at 24 and 3, in the middle of the night, it was discovered I was 9 centimeters dilated, and our girls were coming. I woke up at 11 p.m., and the girls were here at 1:09 and 1:12 a.m. All things considered, they weren't a bad weight. Amelia, twin A, was 690 grams, and Harper, twin B, 680. Because our OB had been so upfront with us, my husband and I were really just thankful to make it to that point. We were scared, but neither of us had expected we would even make it to 24 weeks. We knew we had done everything we could to get the girls to that point, and now we just had to trust the teams taking care of them. So I'm going to focus my discussion today on Harper, twin B. She's the little one without the hat. Amelia, twin A, had her own challenges and complications in the NICU, but from a nutritional standpoint, she was pretty boring. She spent her entire NICU time on full feeds with human milk fortifier, tolerated it well. Harper, on the other hand, was anything but boring. Harper began her feeds on donor milk and was able to switch to my breast milk once I could provide it. They also started her with a human milk fortifier. My memory, to be honest, was a little bit foggy at this time. I can't speak to when exactly we started the fortifier. Within a week of being in the NICU, Harper had her umbilical line extravate into her abdomen, spilling TPN and SMOF into her tiny belly. Luckily, it was spotted very quickly, and they pulled a large volume out. They then started her on antibiotics. She was touch and go for a little bit, but amazingly, she recovered. She was able to slowly get back to full feeds with the human milk fortifier. She bounced back from that, responding well to the preventative antibiotics she was put on. Then one night, she had a bloody stool. With her extreme prematurity, the team was on high alert for neck. Harper was put under close watch and x-rays were ordered, but she remained an alert and happy baby. The dietitian discovered my own extensive allergy history and now knew that Harper was at a high likelihood of having allergies herself. The dietitian told me about a new fortifier, this one being in liquid form, where the proteins were so broken down that a baby couldn't be allergic. So we switched to this. After this, there was no bloody stools, but Harper slowly started to show signs of an infection. Her temperature would fluctuate, her x-rays didn't look great, and then she started vomiting. She quickly became very sick. She was now NPO and on TPN. She stayed on TPN for over a month. This month was Harper's hardest in the NICU. We never were sure of a source of infection. At one point, we did find pocketed fluids in her abdomen, which we assumed was behind it all, and probably caused by the umbilical line leaking in her abdomen early on. An interventional radiologist came to the unit and inserted a pigtail drain. They were able to get a large volume of fluid out of these pockets, but they never grew anything in culture. Harper's platelets started to drop. requiring transfusions every 12 hours. Ultrasound after ultrasound, they couldn't find the source. She even had an MRI to rule out a subarachnoid abscess, which wasn't there either. Over this time, she required close to 40 blood transfusions. She became unrecognizable with her edema and jaundiced skin. Her kidneys started shutting down, and there were hard talks about possible dialysis. But then, slowly, she started to improve. She had increased urine output, and her edema went down, and she even started to pass stool. The doctors later assumed the infection was due to a septic ileus. During all this time, we had to trust the team we had. We had numerous hard conversations with the neonatologist, but Harper started to improve, eventually starting on full feeds again. And at this point, she was just over 31 weeks. Shortly after, I had a meeting with myself, a neonatologist, a resident, and a dietitian. They pressed upon me the importance of starting Harper back on the liquid milk fortifier. They went through all the benefits, as well as how they were confident that in the liquid form, Harper would not be allergic. I had put my sole trust in these doctors throughout this process. I agreed with them without question. At this point, after everything Harper had been through, human milk fortifier kind of felt like small potatoes. Afterwards, the nurses seemed surprised I had agreed to restart her. I honestly didn't feel I could choose anything against the doctors. They had saved my daughter's life to this point. They were the experts. I didn't even know what questions to ask, and my sole concern at that time was that she continued to improve from the infection that almost took her life. Harper continued to progress, being extubated and switched to NIPPV and then CPAP, but her abdomen remained distended from the infection. It never fully improved. Shortly after 100 days, we moved to the step-down unit with her and her sister. We were in this new space that actually had windows. But Harper began to have bloody stools again. At this point, she was 39 weeks, a day before my due date. Her latest abdominal x-ray looked horrible, and the surgeon on call was informed. She was put on NPO, and everyone thought it was neck. Over the next 8 hours, she had more x-rays, an ultrasound that even suggested a malrotation with a volvulus, and then a gastric series that ruled that out. The surgeon was able to come in, and she was shocked to discover the x-rays she saw were of my daughter. At this time, besides being hungry, Harper was alert and happy. At this point, the team maybe thought this might be an allergy instead of the neck they were thinking before. And I had had this in the back of my mind ever since I agreed to restart the fortifier. They kept her NPO for 24 hours in case it was neck, but since nothing was getting worse, we were able to start her on Alimentum with some preventative antibiotics. What emerged was a new baby. She was less irritable. Quickly, her belly looked better than it had in months. It made me feel awful to know how uncomfortable she must have been. From here, the girls progressed through the step-down unit, learning how to breathe and eat at the same time. We celebrated Christmas in the hospital, and Harper's edema and color continued to improve. As we moved towards discharge, my husband and I expressed how Harper's cry sounded weaker than her sister's. A few days before we came home, it was discovered she had reflux, and she was started on lansoprazole. Harper was discharged after 152 days on home oxygen, on Alimentum, and lansoprazole. Amelia, her sister, was also on home oxygen and NeoSure. This felt especially monumental for me because we had been lucky enough to stay at the Ronald McDonald House during our NICU stay. Up until this point, I had spent more time living at the Ronald McDonald House than I had at the new home we had purchased. We settled into our new house, finding a new routine. We became professional appointment attenders, physiotherapists, nurses, all while being new, anxious parents. These are pictures of Harper from the beginning till 2 years, when she was 2 years old. Once the girls turned 1, they were now eating some solids, and my pediatrician and I decided it was time to test Harper's allergies. At the direction of our pediatrician, I followed the Milk Ladder Challenge, a study out of the UK. Each rung is a different form of dairy, having been cooked for a different length of time. But of course, being from the UK, some of the foods weren't familiar to me. I was making malted milk biscuits and Scotch pancakes. She initially failed at a certain level. I noticed what I thought was possibly a small amount of blood in her stool. As my pediatrician had directed me, we then went back down a level and stayed there for another month. I then attempted climbing the ladder again, and she passed with flying colors. She currently has no allergies and drinks milk regularly. We were also able to wean down Harper's reflux medication. Luckily, with solids, her projectile vomiting had decreased dramatically. But I did find for some times that when she was coughing, she would sound wet. So we continued the medication until she was about 1.5 years. This is her sister Amelia, the same comparisons. The girls will turn 3 at the end of summer. They're both off oxygen and medication free. Harper's followed by a few teams, but only annually, and they're almost caught up on all their milestones. And as said before, they're silly, sassy, opinionated little girls. They keep us on our toes, and they're lots of fun. We're so thankful for the entire NICU team for getting them home to us, and I just want to thank everyone for listening to a small portion of our NICU journey.
Thank you so much for sharing that with us. And like you said, it's just a small portion of a long journey that you had in NICU. One of the things you mentioned is the amount of difficult conversations that you had with the team. And I'm just wondering, I know that's something I think every NICU team struggles with, is how do we have these difficult conversations? What did you find was helpful for you in these conversations and how to navigate them with the team?
I appreciated when there was a private space that we could go to. And also, when your babies are so little and so premature, kind of every decision, you're not sure how bad it is. You don't have anything to compare it to. So almost moving to that private space was like, oh, this is a big problem. And you knew to kind of brace yourself a bit more and to consider, as opposed to, oh, this is just a normal thing that happens for babies that are 24 weeks and we just have to get through it. And just having that time, and to be, when people can be very upfront and honest. I work at the hospital. I'm a nuclear medicine technologist, so I do have a bit of medical background. And so I just really appreciated when they could be as honest and as upfront. I didn't want the sugarcoating for myself or my husband. We just wanted to know what we could expect and what the plans were.
Well, Jessica, thank you so much for sharing your story and your experience with us. We always advocate for families and to be involved, but also we feel there's a lot of education that is needed. Were you well educated on the choice and decisions that you made with the healthcare team?
I was definitely included. I really appreciated being part of all the rounds, and not just being part of the rounds, but being shown, like, okay, this is what we're looking at on the x-ray, and this is what we're seeing, and this is why we're concerned. I don't know if it's just my own self that I have a hard time going against anything a medical person recommends, and that I had a hard time advocating that way. But I was definitely included in all discussions. But there is always that pressure, right? That they are the experts, and how would I make a decision that's different than what they're saying or anything that way?
Right. Okay, Leah, any other question, or otherwise we're going to move on?
Just to follow up to that, do you feel like you've changed? How would you advocate differently now? Do you feel like you would go against the medical opinion, or are you still in that same spot of let them kind of make the decisions?
I think that I would feel more comfortable asking more questions. I think I would know what questions to ask more. I was pretty careful during our time in the NICU that I didn't Google anything. I didn't try and get involved too much in that way, because you can kind of get in that hole and get too upset. And now that I can look back on it, and I am part in different support groups, and you can hear different stories, you can hear, oh, someone tried this route or someone tried this. Whereas at the time, I just tried to kind of live in what we were experiencing and not reach out as much.
Okay, so Jessica, thank you so much for joining us here today and for sharing your story and your beautiful daughters. We wish you all the best. So thank you for today.
Thank you.
The challenges in NICU often include feeding, as we've heard already today, and our next guest is only out of NICU less than a year, and she's going to share her perspective as a mother on the pressures of feeding in NICU. Aba Mapera is a first-time mom to a baby girl who was born at 25 weeks and 6 days. Baby Dia was born via C-section, and she spent 75 days in NICU. She will soon be 6 months old and 3 months corrected. And while in NICU, she received her nutrition through NG and OG tubes with a mix of breast milk with human milk fortifier and liquid protein. The diet, which was thought to be medically necessary, caused Dia to be severely constipated on some occasions, so much so that she had to go back on supplemental oxygen on the days she didn't have a bowel movement. Aba wanted to exclusively breastfeed Dia. However, she felt like there was a push for early discharge and thus bottle feeding. And baby Dia is, in my understanding, exclusively now breastfed or bottle fed. Sorry. Yes. So thank you for joining us today, Aba, and you have a presentation to share with us.
Yeah, thank you so much for having me. And hello, everybody. Hello, to whoever is watching. So, as everybody introduced me, I'm Abha. I'm first-time mom to baby Dia, and I'm a physiotherapist. And this is baby Dia when she was born. She was actually 850 grams, so doctors were quite surprised at her weight at that gestational age because she was on the upper limit, and which worked in our favor, thankfully. She was born right. Oh, that's her now for her first time wearing a dress. So this is a little background. It was very much planned pregnancy, so we followed doctor's advice to the T, vitamins, regular antenatal care, and everything. Everything was going well till the 25-week mark. Anatomy scan was all good. So initially, I started contraction on November 1st. And then I went to the hospital. Doctor did every test possible. All were negative, and I was allowed to go home and resume my work. The next night, I started bleeding and went back to the hospital. I was kept there for a few days. I received progesterone steroid shot for Dia. And November 5th, at about 2 a.m., the contractions worsened. And I quickly progressed from having, 2 centimeter dilation to 4 to having an emergency C-section at about 4:56. About in 45 minutes, Dia was here. So during her nutrition, she received the human milk fortifier as well as liquid protein. Initially, we found that caused her a lot of discomfort, but as the medical expert said, this was to be expected because her digestion is very immature. We kind of, stayed mum and were bored with it, but around Christmas Eve, she came off her CPAP and she didn't have a bowel movement for about 3 days. She used to be very, very regular. Because when she didn't have that and she was straining a lot, she would hold her breath and she had to go back on supplemental oxygen because her oxygen saturations were dipping that much. At that point, my biggest worry was the ROP because I didn't know much about ROP, to be honest, but all I knew was supplemental oxygen could make it worse. And Dia going back on supplemental oxygen was a big worry because her ROP was already progressing from stage 1 to stage 2. And I was worried that if it would go to stage 3, she might need some intervention. And me having not perfect vision, I have a genetic disorder in my eyes and not having perfect vision, I just didn't want the same thing for my daughter. So we spent countless days beside her bed, just making sure she's not straining too much. We comfort her so that she doesn't strain, doesn't require higher oxygen. So that was a big, big worry. And the moment she passed the stool, she was okay. She didn't require that anymore. And so in a conversation with the dietitian, I spoke about weaning her off that fortifier because to my understanding, that was causing the whole issue of her being constipated. But somehow this was medically necessary and she needed a human milk fortifier, and that was continued. So around about 36-week mark, when she was 36 gestational age, I felt like there was a big push for an early discharge, and I was not prepared for it at all. We were preparing for closer to her due date, what was told to us. And I had no clue about her nightly routine. I wanted to practice breastfeeding because that was my plan, to exclusively breastfeed her. But somehow this just did not happen, and I felt really, really alone at that point, that I wanted to breastfeed, but the doctor was like, no, she's doing well bottling. Like, everybody was like, she's doing well bottling. She should bottle. Like, she's going to give her quick discharge. And that's like, I am happy about quick discharge, but I want to breastfeed. And somehow that went really unheard. We came back home at 36-week and 4-day mark. Since then, I've tried breastfeeding on numerous occasions, and like tried before bottling, after bottling, like different approaches, having a lactation consultant come in for a visit. It just didn't work out. She wasn't interested in breastfeeding at all after coming home. So now she's exclusively bottle fed. We were advised to give her formula with the bottle, like I think a teaspoon of formula with every bottle of breast milk. We tried that. She was severely in pain all the time, refluxing really bad. So against medical advice, I decided not to give her formula, and I was okay with her gaining weight slowly. And that made a dramatic difference in her. Her reflux reduced. She was no more riding in pain for hours after her feed. She was like happy baby, and happy to be fed just breast milk and no formula. And she gained weight dramatically well. She weighs almost 6.5 kilos now. And so yeah, that was our journey. Not very exciting, boring pretty much. But now that we are here at home, we have started with a bottle feeding aversion again at about 3 months mark, and that's kind of continuing. So hopefully we'll have a dietitian in and that would resolve. And that's about it. So thank you. Thank you for listening to me.
Oh my goodness, look at her. She is precious, so sweet.
Thank you.
So, Abha, tell me about the resources. You're saying that you felt like you were kind of rushed out the door by the sounds of things in NICU. And then once you got home, who did you turn to when you were starting to see that there were some issues with the feeding?
So we are followed by the developmental clinic at the hospital. So I did give them a call. There is a lactation consultant there that could squeeze me in before my appointment. However, that was just like one-time thing, and that was just it. And then I was kind of left to my own devices to try different positions or different, like I had the resources in a sense, printouts to try, but it was just me at home trying, from reading from those papers and stuff.
Yeah, so Abha, thank you so much for sharing your story. And I know it's so recent, and I know how hard it is to come and being vulnerable in the very first few months after discharge. So we do appreciate you for doing that and educating healthcare professionals and other parents. And I think also for them to know the journey does not end when you leave the ICU. The challenges come with us, and the support is needed in the community to help the families thrive.
That's true. I would have very much appreciated some kind of forewarning to what comes after NICU, because A, I wasn't prepared. B, all of a sudden you're in home without all that medical support around you, which you're used to since the baby is born, really. And to figure out everything all together can get really overwhelming.
Thank you so much for joining us here today, Abha, and for sharing your story and for sharing those beautiful pictures. My goodness.
Thank
She's
you.
so sweet. Thanks again.
Thank you.
Thank you. And our next speaker is Heather Bradford. She's going to talk about caring for micropreemies, a mother's perspective. Heather is a mother of 3 children, all born too soon. Her first was born at 35 weeks in 2011. Her second at 22 weeks and 5 days in 2015, after fighting for the team to provide resuscitation at delivery, and her third at 29 weeks, just over 16 months later. Since having her children, she has been working hard to raise awareness about advocating for preterm children, especially around informed decision-making and the limits of viability. She has volunteered on the Family Advisory Committee and the Canadian Premature Babies Foundation to bring the parent voice to the table. She was honored to speak at a neonatal conference in 2019, educating medical professionals on the parent perspective of making informed decisions and being in the NICU. And I have here joining us live, Heather. Heather, thank you so much for being here today, for sharing your story. For those who haven't heard from Heather before, she's an amazing mom, advocate, and a great speaker that really inspires us to do better.
Thank you, Fabiana. Thank you for having me.
So if you have any questions for Heather or any comments about any presentation, please send on the comments and we address them after the presentation. Thank you.
Thank you. So as Fabiana sort of introduced, I am a mom of 3. All of my babies were born premature, but I'm going to focus on my 22-weeker today. When I was pregnant with my second child in 2015, caring for the smallest and most fragile babies did not include a baby that was born in the 22nd week of pregnancy. At that time, a baby born that early was not considered viable. Most people don't ever think about what happens if you go into labor or need to deliver at the cusp of viability. I was focused on baby decor, names, choosing what we were going to name our child. We didn't even know if it was a boy or a girl. However, just 22 weeks and 5 days into my pregnancy, my water had broken and infection had set in. I was on the cusp of viability. I had to deliver my baby that evening. However, the conversation that followed set the tone for our entire NICU experience. On January 18th, 2015, a neonatologist came to speak with me. He told me and my family that my child would not survive. I was just too early. He went on to ask what I wanted before telling me that I should stop monitoring the baby, induce labor, and deliver that evening. He told me that my child may not survive delivery, but if it did, comfort measures would be provided until the baby passed away. I would be able to hold my baby and spend as much time as I needed, and I would be supported through this process. However, I was still stuck back at his original question. What did I want? What were my values? What was best for my family? And I wanted to attempt resuscitation. The doctor explained that if somehow the baby did survive, it would not survive past 72 hours. Somehow, if this child did live, it was facing a life of disability, a child who would always rely on me for care. And I needed to consider quality of life and what my life would look like raising this child. I explained that I understood. Even if my child only survived for 72 hours, I wanted to attempt resuscitation. I wanted the possibility of those 72 hours and whatever else may come after that. Once again, the doctor asked what I wanted, followed by encouraging me not to resuscitate. I informed the doctor that if he was going to ask me what I wanted, then I was clear. I wanted to attempt. I wanted to try. That evening, the neonatal team reluctantly attended my emergency C-section. The only chance my baby had at life was to deliver me immediately. I was terrified. The conversations were daunting. Nowhere in any of our conversations did anyone mention any joy or any time that we would spend together and the memories that we would make, even if our time was short. I was quickly whisked away and prepped, and my son was born shortly after. He gasped at delivery. The team attempted resuscitation and was able to stabilize him. Our NICU journey was about to begin. I wanted to take in as much as I could while he was with us. I was adamant that he needed a name. I didn't want my baby to die without a name. He needed to be somebody. Little did I know at the time, that same theme, advocating for my child and their best interests, had only just begun, and he was definitely going to be somebody. He was the boy that changed my perspective and that of many others in the NICU since. Over the course of our NICU stay, there were a number of situations where I felt that I needed to advocate for my son and what was best for our family. Treatment plans, being involved in his care, but most of all, what stands out for me was advocating in regards to feeding and discharge. Our feeding journey began early on. I began pumping right away. Luckily, I was able to provide milk and he was able to receive it early on. As we approached his milestones, we started adding more and more to his diet. He was taking full feeds by NG tube in no time. As we approached his due date, the conversation of feeding came up more and more. I was adamant that I wanted to try to breastfeed. I was told repeatedly that babies born this early often struggle with feeding, and wanting to breastfeed was a very high expectation. Once again, though, I wanted to try. I would accept whatever feeding method was best for my son, but I wanted to at least try. Because I lived a fair distance from the hospital, I was not able to be at many of his feeds. The nurses began pushing bottle feeding. It was a huge success that he was able to coordinate the suck swallow, but moving forward to breastfeeding was still a huge step. I pushed forward. Starting slow and working up to longer feeds, I continued to attempt. I was there as often as I could, putting baby to breast as often as I was able. It took time. I had to learn his cues, not rely on the monitors, be patient with his progress. The staff continued to encourage the bottle, even stating that we would be able to be discharged sooner if I would just bottle feed him. Being home after many months in the NICU with other children at home was enticing. But again, I wanted to try. I was determined. I pushed back. After a slow start, he caught on. We were a week shy of his due date, and he was breastfeeding. He was taking full feeds. We had done it. Once again, we had been told it wasn't possible, and here we were, beating the odds. After feeding had improved and his weight was going up, I started asking about discharge. We were given parameters and goals to meet. One day before his due date, I asked again. We had met the goals. What were we waiting for? The neonatologist sort of brushed off the question, talked about growing, didn't really answer me. The next day, the day before his due date, I said, I need to know what we need to do to go home. Give me a clear plan. I was told babies born so early don't go home before their due date. Once again, I pushed harder. What do we need to accomplish? The team didn't have an answer for me. That just doesn't happen, was all they could tell me. After rounds, the neonatologist came and spoke with me. He asked if I felt ready to go home and if I was sure I was ready to take this on. Bringing this baby home before his due date was going to be a huge task and a big change to our family. Yes, I was terrified. The idea of caring for him at home scared me, but I was ready. He said he would get the papers ready, and we left that evening. Our journey would have been very different had I not spoken up and fought for my son, pushed back a little, and changed what the norm was at the time. I asked to test the boundaries. I asked to try. I always wanted him to be safe and to thrive, but I was not ready to fit into the box of, that's not going to happen, at least without trying first. It has been 7 years since we left the NICU, but I still find myself advocating for his needs. I found myself pushing for therapies, a wheelchair for distance, even though he can walk, and Braille lessons at school. We are so often brushed off because they see his list of diagnoses. They don't see what he is capable of. Just because that isn't how it was or done before doesn't mean we can't change it. For me, it's a reason to explore other options and push the boundaries and give my son the best outcomes I can. It isn't an easy journey. Engage definitely has challenges. He has mild CP, low vision, autism, and ADHD, among other diagnoses. But I've never let those labels determine who he is and what he is capable of. He has also been my inspiration for volunteering and advocating alongside the Canadian Premature Babies Foundation, as well as the NICU that we were in. We have made a lot of changes over the years and will continue to fight for those to come behind us. My son was the only surviving 22-week baby born at the hospital in 2015. However, every year since, there have been more and more of the smallest and most fragile babies given a fighting chance. Thanks for having me and listening to a small snippet of our story.
Wow, Heather, thank you. It's always hard to follow you. Yeah, I heard you speak many times, but it's also very emotional going through the journey with you. And your voice has helped not only your son, but it's been helping a lot of our community. When we spoke at EPIC a few years ago, you had the whole room in tears to hear your story, to hear how well your son is doing, and how much change you have pushed to save those tiny babies. So I'm going to add a comment here that was actually made for Abba's presentation, but applied to you as well. So many people in the NICU honestly don't know what happens after NICU. I know as a NICU nurse, there was so much I didn't understand until I had my own complex little one who spent time in the NICU. He was pushed to bottle fed as well and developed an aversion around 3 months, and he still now has a feeding tube at age of 5. He has a great relationship with food now, but aversions are such a long journey. I'm sorry that Tim didn't listen to you about your desire. It continues here to breastfeed, and you weren't prepared for what came after the NICU. We can do much better in the NICU. And I think, she's addressing Abba's comment about pushing for a bottle feed, which you also experienced that.
Yes.
So now, Heather, 7 years later, what have you seen because of the work that you do that has changed on your perspective?
There have been so many changes, and I've seen families with babies born at 22 and 23 weeks being part of the decision, being asked what they want rather than being told it's just not possible. I've seen hospitals creating medical directives and sets specifically for these babies born less than 24 weeks. I've seen small baby units coming around. It's definitely more talked about. It's more heard of. These 22-week babies are not considered not viable anymore. They're given options to families. And I've also seen a bigger push for involving the families since I was in the NICU. At the time, it was so difficult to go against the medical team and the recommendations or to push back a little bit. But I've seen huge changes in involving families in rounds and in the NICU. And I hope that that continues to be standard practice going forward, because every family has different values and different wants and goals for their child and their family. And having those included is really important in the NICU.
Heather, first of all, it is wonderful to see you. I haven't seen you in person since EPIC.
It's been a long time.
Yes. And every time I hear your story, like Fabiana, as parents, we react. We hear our own stories in there. And I got goosebumps when you're talking. But tell me, how did you personally, besides being an amazing person, how did you find your voice in NICU? What was it inside you that allowed you to advocate?
Well, I worked in a labor and delivery unit as a unit clerk. So unfortunately, I knew that bad things happened. Everyone thinks that the L&D is such a wonderful place, but it is until it isn't. And there's so many sad situations and horrible realities that come with labor and delivery and the NICU. So I had a little bit of background knowledge, but really what stuck with me was the fact that the neonatologist that day asked me what I wanted. And I was stuck on, this is what I want. If you ask me what I want, this is what I want. I understand everything that I am risking with that, but if you're going to ask what I want, this is my answer. If he had walked in that day and told me it wasn't an option, I probably would have reacted differently. But because he started that conversation asking me what I wanted, I stuck to that and I clung to it and I ran with it and continued that right through our entire stay. And even now, when my son has been out of the NICU for 7 years, I still stick to what do I want for him and how do I best achieve that?
Oh, that is wonderful. Heather, we have a lot of healthcare professionals listen to us today, and we saw some comments that we can do much better. How can we work better together? Parents in the ICU with the healthcare professionals. How do we help them understand our point of view, educate us while you educate them from our perspective?
I think taking the time to educate the parents and to give the parents all options. Yes, some of those options may not have the odds behind them, but they're still options and they're worth being discussed. And it's not about giving false hope, but about giving all sides of the story. So nowhere in our conversation did anybody mention that you can still find immense joy and growth and achievement in a child who has a disability. It was all the negative. And they didn't give any sort of inclination that there could be good memories and joy and growth in that decision. So I think that it's really important to give the whole story without giving false hope, of course, but making sure that you know that even if these outcomes may not be what you wanted, you can still find positive in them.
Absolutely, 100%. So Heather, thank you so much for joining us here today, for sharing your story, your insights. We really appreciate you and love having you at the foundation. So thank you so much for being here today.
Thank you.
Often when babies are born early and in NICU, we as families get familiar with the term fortified feeds. And this is a widely used method to help babies grow and gain needed weight. Our next guest is also very familiar with this, as she has had over 40 years experience in neonatal clinical settings. Neonatal nurse practitioner Terry Johnson is a nationally known educator and a frequent presenter at national and international nursing and multidisciplinary conferences. Her clinical interests include the immunobiology of human milk, strategies for the use of human milk in premature and low birth weight infants, and human milk, as we know, has been called a source of more life than we can imagine. And so Terry is going to explore with us now the benefits of an exclusive human milk diet and how healthcare providers can support parents on the antepartum unit as well as in the NICU. Welcome, Terry.
Thank you so much. Let me get my slides up and going. I was so taken by the last presentation, I wasn't ready. Sorry, ladies and gentlemen. So, let me go back here. I must say that all of you parents who have presented today have taken on such an incredible role of being our teachers. I listened to your stories of how you had to advocate for your children, for what you thought was best care, best management, best possibility for improving outcome. And I appreciate, and we who work in the NICU appreciate, your willingness to take on one more job, and that would be to be our teachers, to help us understand what it's like from your side of the warmer or the isolette, so that we can work together for best outcomes for everyone involved, for your babies, for yourselves, and also for that NICU staff who are there year after year working with these babies and their families. So thank you so much for your willingness to share with us today. So I'm going to talk a little bit about caring for the smallest and most fragile babies, Grow Baby Grow. And Grow Baby Grow is actually an initiative that the entire state of California here in the US has, where they collect their data for the year about the outcomes coming out of the NICUs that are in that state. And they have a goal every year with some new initiative. And currently, they're really looking at this Grow Baby Grow model. And so we're going to use that sort of as a jumping off place. So why are the small babies coming? And it's just some history. Now, I'm going to talk to you from both a nursing perspective and nurse practitioner perspective, but I have this really strange background in theology and religious education. And so I look at things both very scientifically and sort of big picture, and I'll try and make those both work for us today as we learn this. But one of the things to think about when we look at the small baby unit, and this happens to be an article live TV article about Prisma Healthcare in South Carolina when they opened their small baby unit. And they actually have the entire unit fairly darkened, really trying to recreate that intrauterine life experience that this peri-viable baby would be having had you not just delivered them. And one of the things I want you to think about is the babies we're seeing today that are so much younger gestationally and so much smaller by weight are not the first, second, third, or fourth, but they actually are somewhere around the fifth generation of a NICU population, if you think of it that way. When I look at US data in neonatology, we look a lot at the musician Stevie Wonder, who in 1947 was born as a premature infant, put in an isolette, excuse me, with 100% oxygen, survived prematurity, but by the end of his first year of life, had severe retinopathy of prematurity and was blind. And if we start looking at the periods of generations, which are usually measured somewhere around 20 years, we're going into that fifth to sixth generation of premature babies. And these babies are unique because of the incredible prematurity of every, what we call, end organ system they have. It's not just their lungs that we function on that. It is their gut, it is their brain, it is their immune system. Everything is at a very, very early gestational age. And a milk researcher here in the US, Dr. Mark Underwood, uses this term that I just love. These are evolutionarily new population of premature infants. As we have gotten better at high-risk pregnancies, as we have gotten better at holding off labor, and then maximizing what happens at the time of delivery, having a neonatal team present, and being able to intervene immediately with cutting-edge technology for these babies, we are seeing more and more of babies just like Amanda, just like Abba, just like Heather had, very, very young infants who go through our NICU experience with us. So why are they coming? And I just love the perspective of history. If you look on your left, many of you are going to be way too young to understand what Life magazine was. But in the 60s, when I was alive and kicking and growing up, it was the magazine to read. And in 1964, in August of that year, the cover edition, and this now, if you can find one of these, is worth thousands of dollars, is when the Beatles came over from England to America. And almost this entire edition of this magazine was about the Beatles. But wedged in there was a 4-page article about what you see there beneath. And what you see beneath was an artist's conception of something that physicians were imagining, thinking that maybe someday we will be able to do this. And if you put this time frame in place, I want you to remember that in 1963, President John Kennedy's child died of prematurity, RDS, Patrick. He was 37 weeks gestation. And that motivated the American Academy of Pediatrics to create the division of perinatal medicine and to say, what can we do around prematurity? And this was a model of that. What you have is a fetal sheep in some type of bag, and circuits, which are just sort of pipes, a box here that's sort of the artificial placenta chamber with nothing in it. We have no idea what it would need to be. And then finally, a way to provide oxygenation in that circuit as well. And there that dream set from 1964. We go over, though, to 2017. And in that particular issue of the journal Nature Communications, a group of researchers out of Children's Hospital in Philadelphia, particularly this was a group led by Dr. Emily Patrid, who is a fetal surgeon expert and researcher there at Children's Hospital. They published a paper in which they were developing a more pertinent, more elaborate, more possible extrauterine system to physiologically support extreme premature baby lambs. And then in 2021, right here in Chicago, where I live, there was a conference here by the Academy of Neonatal Nursing. And at it, Dr. Mia Liszka, who is also a fetal surgeon currently at Mott Children's Hospital in the state of Michigan here, doing an awful lot of work at saving premature babies with a clinical translation of the artificial placenta. And what you see now in real time is a fetal sheep in that model. I will let you know that in the Netherlands right now, they are very aggressively looking at this. They have a different type of setup, but the same idea of an artificial placenta, an artificial womb. And with expectation that that may actually be part of the culture and therapy of the NICUs moving forward within the next 7 years or so. So we are forever pushing backwards that gestational age of viability as we learn more and as we're able to create more models to sustain these babies. But I want to go even further back to this concept of evolutionary biology. Now, when you think about evolutionary biology, we're not going to get all caught up in the word evolution. But I heard you all, because I actually sat here and wrote it down today, different speakers use the phrase evolved, evolving, and evolution, and I have evolutionary. What we are learning about babies is the difference between what nature had done for millennia and what we've seen literally in the last 5 epochs of about a 20-year period, from the late 1940s moving forward. So if you had been pregnant in this period of time over here with the Flintstone family, in that evolutionary model, mother would have had a term baby who only breastfed, who was born vaginally delivery, and everybody would be around the bedside. And in that millennia, that's what babies did. And so what they did was develop how to feed, how to grow based on that model. 60 years later, we now have what's called evolutionary discordance. These babies aren't term. They're not breastfeeding right away. Moms aren't having vaginal deliveries. Moms' pregnancies are extremely complicated. And because of that, we're seeing these babies who are now born smaller and younger and are surviving. And what we have to do is catch up from some of those practices to what is it we can do for them that will improve their possibility for outcome in that NICU environment. So why are these babies so different with their evolutionary discordance? Well, they're extremely premature with very low birth weights. Probably 4 weeks ago, I took 2 different calls from 2 different hospitals here in the US, one of which had a 373-gram baby and one that had a 284-gram infant. And we were helping them with decisions around nutrition. And just to know that though these babies gestationally were very immature, they were also very, very restricted in their growth. They have multi-system. Every system is immature. Limited exposure to what now we call the microbiome, which helps establish the health of the gut. They have reduced antibody passage to protect them from infection. Pre and prolonged rupture of membranes, which sets them up for infection. They have an immature 2 types of immune system. We as humans have innate, which is driven by inflammation and is the earliest one to come on gestationally. And then we have that mature adaptive immune system that comes on later with growth and time. They've received resuscitation, stabilization. They have extraordinary caloric expenditures as they try and generate body heat, breathe, do all of the functions that was being maintained for them by the maternal placenta. Inadequate protein and mineral stores for the energy they need to do these functions. They have a lot of inflammation because of the prematurity. And secondly, that affects predominantly their bowel with the state we call dysbiosis, a non-normalization of the infant's bowel function, especially around inflammation. But the largest surface area where this little baby is going to meet the other in the world. And please remember that immunity is all about self and other. And self for the baby in utero is him, his mom, his womb, his amniotic fluid. They are one. And the idea is that changes with birth at term. But in prematurity, that changes much earlier before these babies have a very mature immune system. And that neonatal traffic area there, from the time it opens in the mouth till it finishes at their rectum, is actually the largest surface area of their whole body. So that's what makes feeding so critical. The largest part of that very small preterm baby that's going to interact with other, and if we think of formula as being other species, it's cow milk based. I've certainly used it throughout my career, but instead those babies were older gestationally. This baby's going to be much more at risk for that dysbiosis. And this is a big schematic for all of us who are clinicians in the room. It just identifies what we said. This was that model pre-prematurity, term well babies, normal microbiome, and they had vaginal deliveries in human milk. But over here we have those very diverse preterm sick babies who have all types of events going on with them and end organ immaturity. And that inflammation starts and it gets maximized by C-sections, getting antibiotics, not being fed, using infant formula feeding first, because again, it's non-species specific. Indwelling catheters, some of the medications that we use. And that inflammation starts. In the gut, we call it dysbiosis. It's essentially this inflammatory state, but it leads to the comorbidities that some of our moms just here were sharing with us that they went through in the NICU experience with their children, as well as in the at-home growing periods, things such as residual effects of necrotizing enterocolitis, bronchopulmonary dysplasia. I heard a lot about retinopathy of prematurity and late onset sepsis infections that we heard about with Amanda's twin. So what is the definition of evolution? Well, it's any net directional change or any cumulative change in effect in the characteristics of any organism or a population, and it takes place over generations. Now, I actually wore, this is not me, I will not identify myself as this person, I actually wore that uniform in nurses training. And we had a no visitation policy in that premature nursery that I was in. And what has happened in those 5 to 6 generations since this was the level of care and experience in the NICU is a drastic reformation. What we have now are these tiny baby units. And I'm teaching an awful lot all over the country and outside of it about these particular models of care. And in the small baby units, or in the NICU unit, as Dr. Narvi talked about, within your own NICU, but that they're sort of segmented into one special area with a certain management team. These very small babies, the models for their core measures are making that environment more healing, that you partner with the families from the very beginning. Positioning and handling are paramount, and also being skin to skin with their mothers. Safeguarding sleep, minimizing stress and pain, protecting skin, which is so very fragile in this population. And the one we're going to talk about for just a few more minutes, optimizing the nutrition that these babies receive. So there's that Dr. Mark Underwood again. And he states in his paper, the growth and neurodevelopmental needs of these evolutionarily new population of very premature infants are best met by the appropriate fortification of human milk. There's 2 factors there, appropriate fortification and human milk. Appropriate fortification speaks to the fact that we in the external world of the NICU, as of yet, don't have that artificial placenta. We are trying desperately with intravenous and with enteral gut feedings to try and match the nutrition delivery that healthy placenta does, that helps that baby to grow. And the one factor I always like to just toss out to folks to give you how fast these babies are growing is that in this baby's brain right here, they are making 250,000 brain cells per minute at 24, 25, and 26 weeks gestation. And every other organ system is doing the same. So nutrition is empirically needed to be given to these babies in ways that they can absorb, utilize, and have the least intolerance of while they're in that NICU period. So this was a very interesting paper that came out by Christian Smith et al., talking about human milk as a biologic system. And I want to spend some time about that. We tend to think of it all the time as a food, which it is. But more importantly, it is a biologic system for that baby's development, particularly around the immune system, and about being able to slow down, turn off inflammation, which is that driving force for things like BPD, ROP, NEC, the things that we call the comorbidities of prematurity. So it is now we're looked at as a biologic substance that's function is more important than any one thing it does. It does many things, but it's more important than any one thing. And when we talk about the parts of human milk, there are easily identified over 100,000 individual components besides the food part, the nutritional part of human milk that exist in that biologic fluid. When we look about its origin, and this is something that I've been reading about, thinking about, learning about now for about 2 to 3 years, and how it impacts the life of our premature infants, is the evolution of where we get to human milk from what. For years, we thought we waited for mom's milk long after the baby was born. Then we realized that there was colostrum. In the 40s, 50s, we began to look at amniotic fluid. By the 70s, 80s, and in the 90s, we can now make amniotic fluid. There's actually a patent on it that's being used in some research that's going on. But womb milk, I didn't know about for the longest time. So if we started literally conception, up until the time the placenta gets made, that baby has a substance called womb milk there that the mother provides. It has some immune properties, some nutritional properties, and it keeps the little embryo alive until the placenta forms. Once the placenta forms, we begin the making of amniotic fluid. It's a unique thing and substance of itself as well. That baby is immersed in it, swallows it internally, goes into the lungs, the gut, is taken through the whole body, goes to the kidneys, passes out in fetal urine, and then circulates around the baby again. Then there's colostrum. It is the most underappreciated of all the biologic human milk fluids that we talk about. Colostrum has the highest amount of antioxidants in it. And what makes that, what I want you to think about with that, antioxidants are what help the baby not get so much inflammation in their lung. It has to do with moving from being in utero, where oxygen levels are very low, to coming out and being born, and we have to get oxygen levels up very fast. Nature thought about it long before we did with a ventilator. And where that all is in colostrum. Then mom's full breast milk, and then other along the way. And what happens is the baby moves from there's just him to his immune system developing to where he can be interacted with by other, even microbes that are going to be part of the world that he's in, but also just something that's not self for him and decrease that inflammation. Human milk then is biologic in that form, and it has very similar properties to blood. There's over 100,000 components that make up our red blood component. Over here, there's greater than 100,000 components that's in human milk. And I have the privilege when I work to work with human milk scientists, and we have quite a collection of them and their expertise where I work. And those individuals in our facility in the lab frequently move between the blood banking side and the human milk side. And they reference human milk as the white blood. The similarities between the two are significant and quite robust. And human milk then is a biologically active delivery system to the baby's developing immune system. He would have gotten much of that in utero had the pregnancy continued. But in his case, he was born early. So it's coming through now in the gift of and the delivery system of that human milk, which is what makes it so important for our preterm population. So you have the situation where this little tiny human with his global immunologic organ just beginning to develop, and he meets up with human milk from his mother, which is a biologic system, which results in this very profound statement by Grower et al. The amount of human milk an infant receives, particularly this infant to the left, who did not stay around to get that from the mother coming across from her placenta in utero. The amount of human milk an infant receives is potentially one of the most significant and modifiable. I've told you why it's significant. It's modifiable because all of these mothers who shared their story today advocated strongly, knowing that was the best diet for their babies. And we, as consultants to families, we as skilled practitioners need to realize that we may have to modify some factors that affects the preterm infant's outcome by supplying them with a diet that's different, an exclusive human milk diet until they're gestationally older, when inflammation is less a threat on all those developing organ systems. So that makes for what we call the exclusive human milk diet. It is all human milk source nutrition. There is no cow milk in it. The greater part of my career was spent using formulas. I saved a lot of babies with them. I also used something called the baby bird ventilator. They don't exist anymore. Why? Because our babies are younger. They're more vulnerable. And we have learned so much and been able to develop better ways to ventilate and better ways to feed that very preterm infant population. So that diet consists always of mother's own milk first. We want mother's milk because they share the microbiome in the milk. They share factors that are genetically provided, unique between that mother and that baby. And then instead of jumping species, staying in the human species with donor human milk. And then the fortifiers in this case aren't made with cow milk. They're made with donor human milk. And now we're even able to take those products and split them into a substance called cream, which adds calories to the baby's diet. The fortification tends to provide more protein. This helps with weight and weight growth. And if you look at both the Canadian Pediatric Society and the American Academy of Pediatrics, both of those statements say all, not just the babies in Dr. Narvi's unit, not just the babies here in Chicago's unit. Preterm babies, all less than 1,500 grams, should receive human milk, and it should be fortified, absolutely, for these infants. The preferred nutrition is always going to be his or her own mother's milk as the base diet. And then pasteurized donor human breast milk is used as an alternative to formula for hospitalized neonates up until the time we're preparing for discharge. So what I want to leave you with is this concept of prehab. This is the second thing. I've been looking at human milk for the last 2 to 3 years, and I've really been looking into prehab for some personal reasons and also because of my career that I have here, taking care of babies. But prehab is a term that is a preventative mechanism to decrease the risk of injury and to optimize one's functional ability and quality of life. And actually, the person who has spoken more about it until very recently has been a U.S. football player by the name of Tom Brady. He's the oldest quarterback playing in the NFL, which is our football league. He's 46. He is the played 10 Super Bowls. He has had 277 career wins. He has passed a football 624 times for over 10,000 yards in his career. And he absolutely believes in prehab. In interviews, he talks about, I make sure I eat a diet that keeps me well, that I don't get injured, that I loosen up, that I exercise, that I watch my weight, that I watch my diet. And he uses that term prehab in that way. I want to see nursing and medicine looking at human milk as the prehab for these premature populations. It's sometimes called prehabilitations or prevented rehab. You heard these mothers talk about the therapies their children are needing in their postnatal life, secondary to injuries that they received from their prematurity, usually around their lungs, their eyes, their gut. They used to call it prehabilitation or prevented rehab. The goal is, let's cut back on those injuries. Let's reduce them. And it focuses efforts on decreasing the burden on individuals and the healthcare system. And what I want you to hear me say is real important. The term has changed in the long-term outcome literature about neonatal care. We used to talk about former preemies, and they had comorbidities. And in the last 2 years, we've seen an abundance of that language change from comorbidities to the burdens of prematurity. The burdens of prematurity. Your baby got out of the NICU, but not without a burden. ROP, difficulty with feeding, necrotizing enterocolitis, sometimes neurologic delays. How can we prehab them when we're getting them out of the NICU in ways that take an impact on those comorbidities, those burdens of prematurity? And what we do have references for and studies to support is that exclusive human milk diet out to 1,250 grams, just 1,250 grams weight, that consists of mother's own milk, donor human milk, and human milk-based fortifiers. In these studies, reduction in that incidence of necrotizing enterocolitis, reduction in bronchopulmonary dysplasia, reduction in retinopathy of prematurity, and reduction in late onset sepsis in this population of babies. So a person's a person, no matter how small, Dr. Seuss says. So caring for them, be they parents, be they those of us who are clinicals, be those who provide the interventions that we provide these babies and their families. We must always remember that our lift has to be a large lift to move these very small people into a life that is worth living, that is successful, in which they thrive and do well, with the least comorbidities moving forward. I thank you for any opportunity that you have to come and look at our website, learn about what we're doing, and I'm more than willing to entertain questions right now if there are any.
Thank you so much for your presentation.
Thank you.
I do have a question, and this may be just my ignorance of the science of this, but I hear you saying that the preferred method is always mother's own milk, mother to that baby. And I'm wondering, will we ever get to a point where we can actually fortify mom's milk and provide that as the base, or is it such a complex process that we couldn't do that?
What we're able to do is take mom's own milk, which is exactly what our product does. We use donor human milk from donors who have been screened extensively. We are a biologic company. We're not a nutrition company. And so we work at a very high biologic standard. And then we take that donor milk, pull the water out, concentrate it down, and make our fortifier from that we add to mother's own milk. We can make it 24 calorie, 26, 28, or 30 calorie. We also have that as a ready to feed here in Chicago, one of our largest NICU centers. is down at Northwestern, and they have a high-risk maternal oncology high-risk OB antepartum unit. They have 20 beds where all these women are getting treatment for their cancers, trying to maintain their pregnancies. Those women will never be able to use their milk because of the types of medications they're on. So something like a Ready to Feed would give them donor human milk with that fortification, well, protecting them from the drugs that the mothers are receiving. So that's what we're looking at. We always use mother's milk first because it has specificity in the immune system and the microbiome, uniquely between her and that baby. And we want to get those established. Then we use donor human milk before the baby's ready to deal with other in their immune system to drive inflammation down. And then I jokingly say everybody eats a hamburger eventually, but not necessarily in the NICU.
Wow, Terry, thank you so much for your presentation. I actually learned a lot from you. I did not know that the cycle of the breast milk since the womb is amazing to see, and always learning where it's coming from. And when we talk about colostrum as an antioxidant, is so spectacular because we know the benefits of colostrum, and to see the long-term impact for those babies in prehab is really amazing. So my question to you is, like we heard from Dr. Michael Narvi, we heard all these families talk about the push for bottle fed or end up going home on formula. It's 2022. Why are you still convincing people about breast milk for our population?
I don't know, but you have to remember there are some people who still believe the world is flat. Okay, so, but I think the evidence is absolutely compelling. Matter of fact, this past week, a number of my colleagues from work, I didn't get to go because I'm here with you guys, but they're in Austria doing the International Human Milk Conference. Mm-hmm. And scientists come from all over the world. We have it off. We also have it in California on some years, and then out of the country on other years. We are learning tremendous things about human milk and what it can do. It takes a while to change practice. You get into a rhythm of this is what we've always done. And I find it interesting for some of the parents and some of the clinicians that are on this call with a substance we use called nitric oxide that some of the babies need for their lungs. Nitric oxide, whenever you have a baby who's not oxygenating and is very cyanotic and blue and in distress, if you give nitric and he's a responder, it is an immediate response. It's like, boom. And then you think, oh, we have to do that. Human milk is subtle, okay? It doesn't have a lot of excitement to it. It doesn't have this big machine and all this technology, although we have it on our side, making sure that it's safe and reliable. But I think that it's just, we did, most of neonatology was dependent because we didn't have human milk science on formulas and they're being made. And that carried us through, easily up until the 90s. But in the 90s going forward, we certainly have a lot of moms who have milk. They're provided with it. Here in the city of Chicago, most of our NICUs, when they go on transport, take the little snappies and get mom's milk in the delivery room and swab on the way back on transport. My colleague who's a physician down, a neonatologist in Southern California, they have what they call gold bags. They're these little mesh bags that have the snappies in for the mom, instructions on pumping, that they could pump as early and as often, all these bit of information, and they give it to mom on antepartum. I think what happens with human milk is we don't bring it up and discuss it until we're like on day 3 in the hospital NICU. Everything else has been, here's the ventilator, here's the monitor, we're giving blood, there's antibiotics. Getting that early while they're on antepartum, really educating them that your largest contribution to the overall long-term outcome of your baby is probably going to be if you can provide some portion of your human milk.
Wow. So I have a question in regards to the 284-gram baby that you mentioned on your presentation. Last year, we actually interviewed a doctor from Japan who had said the baby there was 260-something grams, and was all over the news back a few years ago. And then he showed how baby had progressed in the first 2 years of life with no major morbidity. And it was the provision of colostrum OIT right from day one, which was amazing to see. And now, what is the protocol for these tiny babies like the one you mentioned in your presentation with feeding from the get-go?
Well, I'm going to show you something that is always on my desk. This is a bean bag that I don't sew, so a friend of mine made. That's 500 grams. She's making me one now since those two babies. That's 300 grams and 200 grams. It's on my desk all the time. As I'm sitting and teaching and thinking and wondering what we need to do next, I just sort of hold it and think, there is an entire life right here in 500 grams. So, what do we need to do? What they were doing with those babies was the idea, what we know with human milk and colostrum is that we can feed a lot earlier because it is self, it's not other. There's not an acute inflammatory response. And that colostrum in particular, not only does it have all the anti-inflammatories and antioxidants, it also has the largest amount of human milk oligosaccharides, which are part of the immune system, protective part of the immune system in it, to go ahead and give them and to feed on first day of life. There are a number of physicians who with human milk feel they can start initial feedings on many of these young babies and then progress forward. And we do have data, and that's not just experience, that's data of the ability to initiate earlier with human milk and to fortify sooner and to wean faster off of TPN. TPN is a lifesaver, but it is also something that causes harm to the liver. It can increase the risk of infection because you have a line in place. So how fast can we get back to feeding enterally? And a phrase I use a lot is, the gut has always been fed. Since conception, there's only been fluid in the gut. It's getting the right fluids in the gut that aren't going to be inflammatory. So having colostrum, there's no one I know that's banking colostrum now, but the closest we're getting, I think it's really helping, is having mom's colostrum in the delivery room. Literally, she pumps while we're getting ready to transport the baby, and then take that and swab on the way. And then donor milk. Donor human milk gives us a very great alternative until mom can get her own milk volume up. Remember, you have to remember mom's ability to make milk is as premature as her premature baby. So she's trying to get that started, but it's going to take her a little bit of time as opposed to a woman who got to 40 weeks. And so having her milk available and donor human milk, nothing that's not species specific in those early weeks.
Leah, any question? We have lots of comments on the chat for after. Carrie, you can check there.
Wow. She has a beanbag too. I love it. Somebody else has a beanbag.
Terry, I actually do have a question, because obviously now there is more information available for families regarding fortifiers. And sometimes when we hear from families, oh, my baby got a human milk fortifier, that we don't really know what it was, because we all of them are called HMF. As far as we know, the labels haven't changed. So how are families being educated and healthcare professionals educating families that there are options now? Because I know the situation in Canada, but you, from your perspective from US, there is a very different healthcare system. How are you educating families with the options there?
We certainly have a lot of things that I would invite anyone in Canada or out with the North American continent to go on our website and look at some really good educational materials for parents to look at about that. Secondly, like the hospital in Southern California, where the neonatologist, who also has a lactation IBCLC, said we've got to get the idea of pumping for mom earlier and then naming it differently. And I want you to hear, HMF was a lifesaver in my career because we didn't have anything like that for our babies. We were literally mixing bottles of stuff, trying to create feeding at the University of Florida for these preterm babies. And so they took the formula companies doing that. Now what we realize is the biologic human milk companies can use similar processes and use human non-cow. Again, it has to do with the immune system of the baby. The only thing he's got at that gestational age is inflammation. And that inflammation leads to all of those comorbidities. And so we do the same thing with that. I think the exclusive human milk diet is what we call it. But you're absolutely right. Many parents think when they say, the baby's getting HMF, they think they're getting human milk fortifier. They're getting a fortifier for human milk. It's just that this newer way that we have, there's a juxtaposition between the two terms. So I would encourage parents to ask for an exclusive human milk diet. I don't want any cow milk in my baby's diet while they're that premature. And what can we do to make sure that happens for them? I think it's really important if you're on antepartum to advocate for that early so that the NICU can be prepared when your baby comes there to provide that particular diet for them.
Terry, I have one last question. It was actually a question for Dr. Michael Narvi that came on the chat. Because the recommendations for babies less than 32 weeks, what if babies are over 32 weeks and have feeding tolerance? Would that fortifier still be applicable to those babies?
Okay. The product that we've made was made for studies that started in 2004 and 2006 and 2007. And at that time, there was a randomized controlled trial. We just picked I had nothing to do with it. I was around, but I didn't have anything to do with the paper. Chose an endpoint. We would do it for so long and see. So the babies would start. And those babies in 2004 were maybe 24 weeks, maybe 25 weeks at the most, at the best. They weren't the younger babies that we're seeing now. And then we had to have an endpoint to know when do we stop therapy, because it was a product that was going for review by the FDA, so we couldn't give it to the babies after discharge. There was no way to provide it if they wanted to go home on it. So the break point was 1,250 grams. They just picked that point at around 34 weeks. The other reason they picked 34 weeks is that an elegant paper by Dr. Yee, he found that necrotizing enterocolitis really begins to drop off at about 34 weeks, the incidence of that we see in premature babies. There are some of those outliers, and it's so tragic when that happens, but the greater majority, if you're going to see NEC, you're going to see it earlier to that. So we felt like they were somewhere near a safe point to do that. The diet has not been able or been studied for release outside of the NICU population. It is also can be used in the surgical intensive care population, but it's for in-hospital use at this time. What we do recommend for families, if they want to continue an exclusive human milk diet after discharge, is the use of donor human milk. And by that point in time, using cow milk-based fortifier, because we're not able to sell it outside at this time.
Okay, so Terry, Leah, have any further question, or you're wrapping up?
No, I have had such a lovely time with all of you. So many times when you're a clinician, you spend some of the worst days ever with a family. And there's an intimacy that happens where I think sometimes they become part of our family and you bring us into your family as well. And then to come back today and to see your ladies and your babies, to hear your stories, you save us so many times. I know that sounds silly, but it really does. To be able to hear how they're doing, see the success of what you're doing with them at home, and to think that it takes a unit with 50 physicians. I mean, Ohio State University, the Dr. Novi was talking about, at one point had 50 neonatologists. I can't even imagine. 300 nurses. It took them to take care of your baby, and we just wave at you walking out the door. And there you go with this little bundle all by yourself, and you guys just rock. So thank you so much for sharing your stories with us.
Wow, Terry, thank you so much for being with us today, for educating us and teaching oh my God, 40 years of knowledge in half an hour presentation. It was amazing. I'm so grateful, and I hope you come back and share more with us.
Anytime. Thank you so much. I would love to.
Thank you. And Leah, thank you so much for hosting with me once again. It's always nice to have you here. and crying together on the backstage. Because that's what we do when the parents share their stories. And yeah, so I'm always grateful to you for joining our live sessions.
Thank you, Fabiana. It's always so great to learn so much from these sessions. And it's an honor to just hear family stories and the latest research. So thank you for involving me.
Thank you. And to all of you watching us live today on our YouTube channel, Facebook, or Twitter, thank you so much for joining us here today. The video of today's session and all the videos from our live series are available on the CPBF website, which is right here, the CanadianPreemies.org. And we want to thank Prolacta Bioscience for sponsoring our educational programs and for the ongoing support to our organization. And we are a charitable organization, and we believe that through support and education, we can empower families, ensuring they're ready to care for their babies. Visit our website, consider making a donation. Together, we can create a brighter future for all our families. And I see you again on Friday, 1 p.m. Eastern Time. Thank you. Stay well.